Okay. Hi guys, I'm Laura and I'm a fourth year medical student. And I remember being where you are 2 years ago, preparing for sitting the second year exams, and I know it's a lot of content. So today we're going to be covering somatosensory systems and pain, and I'm mainly going to focus on the part A, but I have also added more slides to this presentation, which I've hidden, so you can fill in the feedback form and then get access to those extra slides if you'd like be interested in writing an essay for part B on one of these topics. So the aim of this talk is to cover somatosensory receptors, then the dorsal column system, the anterolateral system, spinal cord lesions, and the cortical representation of somatosensory information. So it is quite a lot of content. So the aim is to give you some practice questions and then like some content. So hopefully by the end of it, you'll feel a bit more confident in this quite common part A questions. Okay, so just an introduction. The somatosensation is the body's ability to perceive and interpret physical sense. So that has different modalities, including noxious stimuli, which is interpreted as pain in the brain, temperature, proprioception, crude touch, and fine touch. And just overall, all of these different modalities are then transduced by different receptors, and then they go up the spinal cord through different paths. And we'll cover which ones go up in different ways, but overall, just think about it from receptor to spinal cord and then brain. And sadly it is just like a memory game. You just have to know this system is for this type of receptor. But hopefully by the end of this talk we'll all be more confident on answering these questions. So to begin, I want to give you guys a warm-up quiz. So if you have a bit of paper with you, you can answer the questions. This is from a really old past paper from Oxford. So first, which type of skin receptors responds to touch stimuli? And where are the cell bodies of the neurons that convey somatosensation? From the skin to the CNS. And which neurotransmitter do neurons that convey nociceptive information use? And information from nociception is mainly conveyed to higher brain centers on the contralateral side of the spinal cord. What do you think, true or false? And then dorsal column nuclei are the first order relay for some dorsal root ganglion cells. So I'll give you guys a few seconds to jot down these answers for yourself. And we'll go through the answers after we've covered some content. Okay, I'm going to move on unless anyone has any objections. Okay, so for receptors, there's different characteristics for our receptor. For, as we said before, the modality, which means like what type of physical sense they're responding to, light, temperature, and also sensitivity, which can mean does it have a low threshold or a high threshold, and how they adapt. For example, and what apocenian corpuscle you probably come across. So what adaptation means is if they adapt slowly, they just keep signaling the receptor, or if they adapt quickly, maybe it gives out a signal at the start and then it stops, the receptor stops signaling because it adapts to the stimulus. So, for example, in the Pacinian corpuscle, this is quite a small detail and you don't need to know for part A, but if you wanted to write an essay, it has almost like a balloon. And so when you sit down on a balloon, you first have a stimuli, but then if the balloon is just in the same size, then it is not going to have any more stimulus. So it's the same reason of if you sit down, your brain doesn't need to know every single moment that you're sat down. It's just more important that first it's told your brain that you just sat down. And finally, there's different fibers and system. And what I mean by system is essentially the pathway that it goes up the spinal cord. So as we've quickly gone through, there's different types of modalities. So mechanoreceptors, proprioceptors, which is about the body's ability to sense the position in space. So that's quite important. For example, if you close your eyes, you can still know where your body is. And temperature and chemoreceptors, and finally nociceptors, which they detect noxious stimuli. And as we said, it's presented as a pain in the brain. So this is probably something worth remembering for the part A, is that the Meissner's corpuscles and Merkel's discs are for a small receptive size. And what this means, because they are really shallow on the skin, they can sense like a really small pinprick, whereas the Pacinian corpuscles and the Ruffini endings, they have a much larger receptive field size because they're deeper. So it's just they have less sensitivity, so they just pick up a broader area. So that's something worth knowing. Imagine like a pinprick or just like a bigger area that they sense. And then for rapid and slow adaptation, it just the way that this works, the Meissner's corpuscles adapt rapidly, the same as Pacinian corpuscles, as we discussed, whereas the Merkel's and Ruffini's endings adapt slowly. So one way to remember is that, okay, of course, you know the Pacinian corpuscles are rapidly adapting, but sometimes I think Meissner's is like smooth, so that's like fast, whereas Merkel's is like rougher in my mind, so they adapt slower. But I don't know if that might help you just remember. And nerve fibers. So you've gone through this in your previous lectures probably. So you have A alpha, A beta, A delta, and C fibers. The main thing I want you to take away from this is not the exact speed, just because if you memorize a number, then in the part a different number might come up and throw you a bit off. So the main thing is about the principles, that the A alpha nerve fibers, they're thick and they have myelin, so they're really fast, and these are the fastest. And they're mainly representing proprioceptors, such as muscle spindles and Golgi tendons, which I think you'll go in a bit more detail in the motor lecture. Whereas A alpha beta, they're also thick myelin, but they're a bit smaller, so they're medium in size. So they're slower at transmitting the impulse than the ones with a really thick diameter. And these are in charge of all of the skin mechanoreceptors. And then finally, the A delta and C, you can think of as pain and temperature. And important is that A delta has a very thin myelin and they're small, so they're even slower, whereas C are the slowest of them all because they just don't have any myelin. So just to then move on a bit more detail on the nociceptors, is that the A delta essentially, they're telling you the localized where the pain is, whereas the C fibers, they sense way more different things like this polymodal, so like acids or temperature and other chemicals that elicit pain. But comes as a later sensation and it's not localized, but it's more burning and lasts for longer. Importantly, compared to the mechanoreceptors and proprioceptors, nociceptors have much higher thresholds and a large receptive field. Because the main thing from them is that they want to sense, is there pain? And there's not so much worry about, for example, defining between two different dots, like with touch. And for this one, you have A delta, you have glutamate, whereas for the C fibers, usually it's glutamate and substance P. And this is one of the answers, perhaps, from the warm-up quiz. So, okay, so as we said, the nociceptors, the C fibers do not adapt, but they can become sensitized. So with the chemical soup, like bradykinin, etc., that you don't have to know the detail for part A, then you can get more sensation of pain. That's known as hyperalgesia. So the painful becomes more painful. Whereas with allodynia means where typically painless stimuli, such as touch, can then later be perceived as pain due to some aberrant wiring. But this is like a long-term response, whereas hyperalgesia is usually you have an injury and you have some chemicals thrown about because of the injury, and then it will just hurt more because it's a protective response. So just coming on to this, the relationship between nociception and pain is not linear, and it can be modulated at many different steps, which we'll further discuss. And it's protective, essentially to help you learn from experiences and get away from the thing that's causing you harm. So, clinical relevance. Because the C fibers and even the A delta fibers are smaller, anesthetics usually act more selectively on these, and it can preserve touch. So for example, in a surgery, the surgeon might say, oh, you might feel some tugging and pulling, but it shouldn't hurt. So if it hurts, then the anesthetist can give more of local anesthesia. And the regulator is use dependent, so that means the more the fiber depolarizes, the more it's blocked, which is really useful in this case. And furthermore, you can also do some neurophysiology studies to find, for example, a diagnosis of a nerve disease, and that's a specialty in itself. Okay, so that's us covered with somatosensory receptors. Anyone have any questions at this point? I can't see the chat, so I think we'll move on. If there's any messages, it might pop up. Okay, so the main thing with these two systems in somatosensation, we're talking about the dorsal column and the anterolateral system. So the dorsal column mainly carries fine touch, vibration, and proprioception, as we were talking about, to provide accurate and detailed information, whereas the anterolateral system is mainly about noxious temperature and crude touch. So it's adapted to be sensitive to noxious stimulus, but not super detailed. And where this is very important for the part A, because you probably get a diagram like this. So here, the dorsal column is here at the back, whereas the anterolateral system is here anterolaterally. And how can you tell that this is anterior or ventral and this is dorsal? My main trick is that you can see here, you have this dip in the middle, and this is called the ventral median fissure, which is a very good clue, this ventral median fissure. So it basically tells you, if you can see this part, then this means this is the front. And something I used to remember it's like a Pac-Man. The mouth is at the front. Okay, so we're talking about the dorsal column system. And we said this is to do with fine touch, vibration, and proprioception. So the main thing here to remember is that you have three different order neurons that transport the information from all the way from the skin to the brain. So the first order neuron is the first one that goes from the receptor to the spinal cord. And the thing to remember is that it doesn't decussate. Decussate means crossing over. So it goes all the way to the spinal cord, and then it ascends on the same ipsilateral side. and it goes all the way up to the medulla, where it meets some dorsal column nuclei. And you might come across these words before or not. I remember when I was in second year, some of this content was new for me at this point in the year. So the main thing is that from this nuclei is where you have the meeting point to the next neuron, which you relay is the second order neuron. And the main thing to remember is that the first order neurons travel from the legs and from the arms through different parts of the dorsal column. So the legs go through the fasciculus gracilis and then meet the gracilis nucleus in the medulla. Whereas the lateral part of the column carries the information from the arms, which goes from the fasciculus cuneatus to the cuneatus nucleus in the medulla. So just to explain this through here, as we said, the medial part has the gracilis, and the lateral side is the cuneatus. Gracilis is for the legs, and cuneatus is for the arms. And then furthermore, then you move on from the second order neurons to then move on to the so the second order neurons, then they basically cross over, so they're decussate from the ipsilateral side to then the contralateral side, as we can see these yellow ones, and then this forms the medial lemniscus. So what this means is the dorsal column, which we were talking about first, that was in the spine, basically becomes the medial lemniscus here and projects to the ventroposterior lateral in the thalamus. So in the thalamus is basically the relay station that you've learned about, and then just goes to other parts of the brain like the cortex. So just to say then, from the third order neurons, we said from the thalamus we go to the somatosensory cortex through the posterior limb of the internal capsule. So I must say that that was a lot of information given all at once, so we can just recap it now. So first of all, we had the receptors on the skin, which they're the first order neurons which go to the spinal cord, and those neurons have their bodies in their dorsal root ganglions. And then this first order neuron ascends ipsilaterally, so on the same side. If it started on the left, it goes up on the left side through the gracilis and cuneatus fascicular, and then it meets the dorsal column nuclei, which are named the same, gracilis nucleus and cuneatus nucleus. And once at the medulla, then they cross over to the other side to ascend contralaterally as the second order neurons. And this is called the medial lemniscus. So it just changes name from dorsal column to medial lemniscus. And then they reach the thalamus in the ventral posterior lateral nucleus of the thalamus, and then go up to the somatosensory cortex. And a trick to remember what is the difference between gracilis being legs and cuneatus being arms that I used when I was in second year is that gracilis I think of as graceful, so like graceful legs, and then I just think cuneatus is the other one, so that must be the one for the arms. So initially, yes, this information from the dorsal columns is maintained all in parallel, which is compared to the anterolateral system with pain and temperature, where there's lots of convergence of the signals. So to reiterate the dorsal column, the signaling will be precise and accurate for this reason, but at the cost of sensitivity, so it'll be less sensitive. And the importance of the dorsal column nuclei in the medulla is that once the information gets up there, then there's some inhibitory interneurons which allow for surround inhibition. And what that means is that if there is a signal in the middle, then the ones on the outside will be inhibited just to have a crisp edge. And this helps with the 2-point discrimination. Okay, so that's us done with the dorsal column system. Has anyone got any questions on this? Nope. Okay, so we'll move on. So as we mentioned, the anterolateral system is mainly involved with pain, temperature, and crude touch. So one thing to remember is that the anterolateral system is not only composed of the spinothalamic system. So the spinothalamic is basically what we think about in terms of pain, temperature, crude touch, which I told you at the start, and it's involved with the conscious perception of pain, temperature, and crude touch, just to reiterate. But there are other projections as well that travel in the anterolateral system, and this includes the spinal-reticular and the spinomesencephalic systems. So spinal-reticular ascends through a spinal cord and goes towards the reticular activating system. And you might have come across this in your sleep lectures. Basically, the reticular system is to activate the alert system in the body. So, and it kind of makes sense because if you had a signal of pain, then you're wanting to be more alert, and that's called spinal reticular. And additionally, you also have this spinomesencephalic, which instead is a descending down from in the intraocular system, and is to do with pain modulation. So you can turn pain on or off, and it's what we discussed at the start. Like you can have an input from your brain to say, actually, I don't want to feel so much of this noxious stimulus. And this mainly comes from the periaqueductal gray of the midbrain. So an additional thing to note is that the spinothalamic tract can be further divided into anterior and lateral. And the anterior one is in charge of crude touch, whereas the lateral one is involved with pain and temperature. So the main thing with the anatomy is that the first order neurons from the anterolateral system usually go up and down Lissauer's tract, which is basically another pathway that amplifies nociceptive signals, and this can be either up or down 1 or 2 vertebral levels. And that's something important to remember for later. And so this first order neuron then synapses in the dorsal horn. For example, it could synapse in the substantia gelatinosa, which we'll talk a little bit more about in a second. So when the first order neuron first synapses into the dorsal horn, which is this one, it can go from the laminae 1 to 4. Laminae is basically just another way of dividing the dorsal horn into different structures. And the substantia gelatinosa is important to remember because it's the site of the descending pain modulation. So as we mentioned at the start, the we have the spinal mesencephalic from the periaqueductal gray descending down to turn off pain. That's acting at the substantia gelatinosa. And another thing you might be asked about is the nucleus proprius. Just think of it as the mechanical and temperature. But you probably don't need to know the detail of what lamina it is involved with. But it's probably important to know that the substantia gelatinosa is lamina 2, and it's important for pain modulation. Okay, so we said the first order neurons synapse onto the dorsal horn. And then an important thing that is different to the dorsal columns is that these second order neurons in the anterolateral systems immediately or decussate, so they cross over to the other side through the anterior commissure. Can you see my cursor, by the way? Just say yes or no in the chat if you can. Perfect. Thank you, Daria. So the second order neuron just immediately crosses over to the other side. And so then we're ascending contralaterally. So if the pain came from the left, we're ascending on the right of the spinal cord. And this is important in Brown-Séquard syndrome and syringomyelia, which I'll quiz you on later. So finally, we reach the thalamus, and then we go from the thalamus to the cortex, and this is via the posterior limb of the internal capsule, then the same pathway as the dorsal column. But I think the main thing to remember from this is that the dorsal columns, after synapsing, they just ascend ipsilaterally, whereas the anterolateral system decussates immediately after, and then you ascend contralaterally instead. Now, just a bit more on modulation. The main thing with modulation in the substantia gelatinosa of the dorsal horn is endogenous opioids that could include endorphins, which we might have heard about in exercise, enkephalins and dynorphins. So the main thing is that opioids lead to an influx of potassium, and this hyperpolarizes neurons in the substantia gelatinosa. So essentially means any noxious stimulus is not going to go up to the brain. So it's basically just depressing the signaling here. And there's also something called gate theory, which you probably come across. And it's essentially a theory that says that if you rub like a spot, so the mechanoreceptor fibers, they activate an interneuron, which then turns off C fibers. So this is something that has some controversy to it. And if you wanted to include that in your essays, it's probably good. But just know of it as this version if it comes up in the Part A exam. Okay, good. This descending modulation of pain, it mainly comes from 3 different places in the brain. So one of them, as we said before, is the periaqueductal gray, which releases serotonins and enkephalins. And it's this blue one with the arrow. And this one came from one of the past papers on Canvas. So, and it's something I don't think they would make us have a look into the midbrain like histology or anatomy, but just to remember, it's just a bit lighter than the surrounding part of the specimen. And then the locus coeruleus, that one has noradrenaline as the descending pathway, whereas the dorsal nucleus releases serotonin. And all of these act as the substantia gelatinosa. Just to recap, that's where the first synapse meets between the nociceptor afferent and the pain projection neuron like up the spinal cord. So it's the first order neuron meets the second order neuron for the first time. Cool. And just for completeness, there's also another part of the somatosensory system that you have to know about, aside from the dorsal column and the anterolateral system, which is the spinocerebellar tracts. And as they sound, at least this one sounds a bit more like what it carries. These are to do with proprioception. So from the spinal cord to the cerebellum, which I'm sure you know much about, is to do with integrating signals, one of them being proprioception. And this is an unconscious response. I would say that this diagram is definitely worth learning for the Part A exams. And some things that I will not cover in detail in this lecture is the motor system. And you probably come across that in the next revision session or through your revision. But just a final recap, we have the dorsal column medial lemniscus system that we said with the gracile fasciculus and the crenate fasciculus for the dorsal column, and then the anterolateral system here with lateral spinothalamic and anterior spinothalamic as subsections of it. And extra that I'm telling you here is spinocerebellar, which are here on the side, so laterally. Perfect. So now we have covered somatosensory receptors, the dorsal column system, the anterior lateral system, and we're ready to move on to some practice questions with spinal cord lesions. So hopefully the anatomy that we've just covered will help us answer these questions. So now check how you did with your warm-up questions at the start. We can go through them step by step. So which type of skin receptors respond to touch stimuli? We said Masoners, corpuscles, and Merkel cells, because they're on the surface of the skin. And then, where are the cell bodies of the neurons that convey somatosensory information from the skin to the CNS? Then we said it's the dorsal root ganglions. And this is a bit of new information that we didn't cover. For the face, it's the trigeminal ganglion instead. So it's the dorsal root ganglion for the body, and for the face, it's the trigeminal ganglion instead. And third, which neurotransmitter do neurons that convey nociceptive information use? As we said earlier, glutamate and substance P. And information about nociception is mainly conveyed to higher brain centers on the contralateral side of the spinal cord. And what we learned about was true, because the anterolateral system decussates early and then you ascend contralaterally, whereas the dorsal column system ascends ipsilaterally and then decussates at the level of the medulla. And finally, the dorsal column nuclei are the first order relays for some dorsal root ganglion cells. And this is true. So the dorsal root ganglion cells also transmit some anterolateral, like they also have the bodies for the anterolateral system and some from some others, a proprioceptive system. However, this question is just asking us, yes, is one of them. It's the dorsal column nuclei. Good. So key principles on understanding where a lesion is in the spinal cord for your exams is reflexes, and at what level of the spine is the lesion, and what is the nature of the lesion based on the modalities. So thanks to that diagram with the different systems carrying different sorts of information, if you had an injury on the side or in the middle or to different parts of it, you would affect different modalities. And that's something that you would be expected to pick up on. So just a quick practice. Does anyone want to put on the chat what you think is the level of or the reflexes for the biceps, triceps, knee, and ankle? You don't have to answer all of them, but you can try one if you know one of them. Yes, perfect. Knee L3/L4. Excellent. And if everybody had the chance to jot down in your own piece of paper, we can get the answers now. So biceps is C5, triceps is C7, knee is L3/L4, and ankle is S1. I think in this case, it's very much just like rote memory, but if you try to remember, like on the arm, you have like the C because of the cervical spine, and then towards the legs, it's like lumbar and sacral, then it makes a bit more sense. But for the specific numbers, it's a bit of a memory game. And these are taken from your syllabus, so you will be expected to know these. Okay, so for the level of the spine, if the arms are involved in the injury, in the lesion, then you're thinking it must be above or at T1. Because you might remember from your neuroanatomy classes that the T1 is like under here, and then the C6, 7, 8, like around here. You can do what is called the dermatome shower. If you look that up online, it can help you revise like where each one of them are, because you usually want, if you think about it when you shower, you start from the hand to then go all the way up to the shoulder. And then is the diaphragm involved, then it must be above C5, because a classic mnemonic or saying that it helps you remember this is that C3, 4, 5 keep the diaphragm alive. Okay, excellent. So for these ones, this sometimes comes up in the part A. You might be expected to say what part of the spinal cord these are. And do you have any idea how would you go about saying which is cervical, which is thoracic, which is lumbar, and which is sacral? So the main thing is that, okay, here the colors are inverted. So the outside is the white matter, which is black in this image, which is taken from canvas. And the middle is the gray matter, which might make it a tiny bit confusing. But the main thing is that the cervical spine has more white matter, so more of the white on the outside. Whereas lower down the spine, you have more gray matter compared to white matter. Mainly because you have a lot of information going to and from. If you imagine at the top of the spine is near to the brain, so there's more information going down and then goes to the arms, or information coming all the way from the legs and the arms and the rest of the body. So it's just more white matter in cervical, and then and so on, there is less in the sacral part. And the one thing to identify the thoracic part of the spine is that it has these little things on the side, which are called lateral horns, and then they're mainly involved with sympathetic system. So you think all of your viscera are mainly supplied by this? Okay, yeah. So if you completely transect the spinal cord, then you lose all of the information, all of the different modalities we've been talking about, but also including the motor system. Whereas, for example, if you only had a damage to the dorsal column, then mainly proprioception, fine touch, and vibration ipsilaterally to the lesion would be affected. Okay, so now we're going to go through a case for you guys to solve. So, a 65-year-old man presents to his GP complaining of feeling pins and needles in his hands for the last few months. Over the weekend, he cooked dinner and did not realize that he had burnt his left hand on the stove until later that evening when he noticed the injury. However, the patient can feel touch on his hands, arms, and shoulders when you examine him. So let's think about this. We're saying that he's lost pain and temperature sensation, and also has some paresthesia, that means the pins and needles. However, It has preserved touch and vibratory sensation. What do we think is the system that is affected from the spinal cord in this lesion? Anyone who's brave, you can put it on the chat. So, yes, excellent. So the anterolateral system has been wiped out here. So just try to think about the anatomy of the spine. We know where the anterolateral system is, but then why is it that it's only that one and not the touch? The answer is that this injury is where the anterolateral system crosses over from the one side to the other side, so where it decussates. And we said earlier that this decussation is through the anterior commissure. So essentially in this really rare disease, but it helps to understand and it comes up in your syllabus, is that there's a cyst growing in the middle of the spine, and essentially it just wiped out initially all of the anterolateral system because that's where the neurons are decussating from the one side to the other side to ascend contralaterally. So essentially, this patient had a loss of pain and temperature sensation just on the arms because there was a lesion that stopped all of these neurons from crossing over right from the right to the left or from the left to the right, depending on the injury, but basically because it crosses decussates early. Whereas the dorsal column system doesn't decussate at the level of spinal cord, as we said, it decussates all the way up in the medulla. So it just goes up ipsilaterally, and it wouldn't be affected by this initially. But of course, once this cyst, also called a syrinx, grows and grows and grows, then it will end up wiping out all of the rest of the spinal cord columns, but initially it just presents by affecting the anterolateral system. And this is called syringomyelia. Okay, great. So clinical relevance case 2. This patient had a lesion on here on his right. However, he only lost motor function and has numbness to the touch ipsilaterally, whereas he lost the pain sensation contralaterally. I think I've kind of given it away here, but what kind of lesion do you think would cause this? Exactly, a hemisection of the spinal cord. And can we think why it might be that the pain actually, you still have pain sensation near to the lesion? Yes, exactly, the Lisagos tract, as we talked about earlier, because the pain can go up and down a couple of spinal levels before it goes into the spinal cord. Yeah, great. So as we said, this is called Brown-Séquard syndrome. And again, it would be quite rare because you need to have a lesion that just wipes out half of the spinal cord, say, for example, a stabbing or something else. But this quite well demonstrates the anatomy that, as we said, the dorsal column is ipsilateral, whereas the pain ascends contralaterally. Excellent. Okay, just the last few bits. This is in your syllabus too, but I would just like know the words and it might come up and you would be reminded of it, but it's not really the most important of all of the lesions to know. But basically, you can get other types of lesions that, for example, the subacute combined degeneration of the spinal cord, that this affects the dorsal columns, but also some of the corticospinal tracts. So this will result in problems with the dorsal column, like proprioception, vibration, touch, but also some motor weakness. And this is due to vitamin B12 deficiency. And this can be like lack of B12 in the diet, but it can be quite easily corrected by giving vitamin B12 like clinically, but it's worth knowing about. And especially it often happens to people who have like drinking too much alcohol, and also even nitrous oxide can cause a functional vitamin B12 deficiency, interestingly. And additionally, tabes dorsalis is another type of lesion that affects the dorsal columns, and this happens in syphilis. And essentially, the loss of the dorsal columns leads to an abnormal gait due to the loss of proprioception. Okay, so we're almost there. We have only a small bit left to cover. So you probably covered this a little bit before with the neuroanatomy lecture, so I won't go on for it for too long. But the main thing is that the somatosensation in the brain is integrated. So you have the thalamus, and then it goes to the cortex. And the main thing is that you have a representation of the body in the brain. And this is also known as the homunculus. And the main way I remember, like which way around it is that the legs hang down to the middle of the brain. Whereas, so you have this man like lying down with his feet into the middle. So it's almost like having two of them. And the hands have a bigger representation because you have more receptors coming from the peripheries. So that's the main thing to remember. And the important to remember that it's the legs in the middle, and then the face and hands laterally is in strokes. So the anterior cerebral artery supplies the midline, whereas the middle cerebral artery supplies the lateral side of the cortex. And you can remember, because the legs are hanging down into the middle of the brain, they will be affected by an anterior cerebral artery occlusion. Whereas, like for the face and the arms and that are hanging down here, will be affected by a middle cerebral artery occlusion. So I think the main thing with these two is sometimes it can be a bit confusing, because even though it's called middle cerebral, it doesn't supply the middle. So it's just to remember, the middle cerebral artery supplies the lateral sides, whereas the anterior one supplies like the middle bit. And this will have also some motor effects, but it's just to help you remember. Okay, so that's the end of the content that I wanted to cover today. And I wanted to ask you guys for feedback, please. And I have a QR code here and also a link